Hello, thank you, Mr. Chairman. Dear colleague, it's a pleasure to be with you today in this very interesting meeting. I am Dr. Rabih Azar from the Hôtel de France Hospital and the St. Joseph University in Beirut, Lebanon. And I'm going in the next 10 minutes to discuss with you this interesting complication and that occurred during PCI of a calcified osteoproximal Rca stenosis. So the patient was a 72-year-old female who was complaining of exertional angina. She consulted with one of my colleagues who is a non-interventional cardiologist, and he recommended her to undergo cardiac catheterization because her angina was typical. Her risk factors were hypertension and hyperlipidemia. And when I did the coronary angiography, she had multiple tight, complex calcified lesions, very calcified lesions in the LAD, in the proximal and mid-LAD, at the ostium of the diagonal, and in the RCA, as you are going to see. The circ was a very small artery, so we recommended bypass surgery for her because the lesions were very complex and calcified. But she refused, and she decided to proceed with the PCI, despite the risk of this procedure in those calcified arteries. So this is a picture of the right coronary artery. And as you can see, this artery is significantly calcified, especially at the ostium, where you see a big piece of calcium here, immediately at the ostium of the vessel. You see also significant calcification on the left part of the aorta, on the left cusp, and in the LAD and the left main on the other side. But this is the Rca stenosis, very irregular, very calcified, very tortuous, a long segment of disease starting at the ostium of the Rca, extending all the way to the mid-segment. And this was one of the reasons why I wasn't very enthusiastic to do PCI on this very calcified, tortuous vessel. This is LAD. And again, there is a tight lesion here in the LAD immediately after the takeoff of the diagonal branch. And in other views, the diagonal branch has also a tight ostial stenosis. And as you see, the circ was a small vessel. But this patient refused surgery and decided to have stenting of the LAD diagonal and right coronary artery. And this is what we did. So very quickly, this is LAD. I stented the main vessel and then did the kissing balloon inflation in the LAD and the ostium of the diagonal. And as you see on the right-hand side of the screen, I had a good result. So the next step was to move and proceed with PCI of the right coronary artery. So this is again the right coronary artery. Now I used an extra backup guiding catheter. I don't like those catheters because they tend to dissect the ostium of the RCA. But here, the procedure, frankly, would not have been possible without this catheter. Because in order to deliver a stent to this very diseased, very calcified mid-segment, we need good support. So from the beginning, being aware of the risk, I elected to use this catheter because I didn't feel I have any other alternative than having a good support. And in fact, it was a nightmare to cross the lesion. It took me a long time to cross it, and finally I was able to cross it with an Asahi wire. And you see on the right-hand side of the screen how I was able to cross and get that wire distal in the RCA. And now I took a 1.25 millimeter Aphora compliant balloon. You see the dot here of the balloon. The dot is in the middle of this balloon. This balloon has only one dot in its middle. And it was extremely difficult to get this balloon to the distal part of the lesion. You can see here on the right-hand side, this is the dot of the balloon. You can see how this balloon was pushing my catheter outside the ostium of the RCA, despite the fact that it's the smallest balloon and most compliant balloon that was available. And two of those balloons ruptured during my attempt to dilate this mid-segment of the right coronary arteries. I had two ruptured balloons, so I had to go 3 times with a 1.25 balloon, and the third time I was able to inflate the balloon and to get some dilatation. And this is what I had after the balloon inflation. We dilated the whole segment. But as you can see here at the ostium of the RCA, this guiding catheter, unfortunately, is getting deeper and deeper into the proximal vessel. And I had to do this to deliver the balloon. And the same thing will happen later on. But so far, I mean, the ostium looks okay. There is some haziness in the proximal RCA, so definitely there is some dissections there. But we elected to proceed and now use a bigger balloon to get more dilatation. And this is a 2 millimeter by 15 millimeter balloon. As you see, I could not get it in to the distal part of the lesion. And you see here my catheter, how my catheter is all the way out despite the support that I had. And finally, I had to take a much shorter balloon, a 2 millimeter shorter balloon. I went in, I dilated the distal part of the lesion, I dilated all the proximal part, and I went back in with a 2.5 balloon and did additional dilatation. And this is here the view after additional dilatation with the 2.5 millimeter balloon. It looks better. There is dissection here proximally, but at least now I can attempt and deliver a stent. So I went in with a 3.0 by 20 millimeter Promise Premier stent. And again, it was extremely difficult to get it to the lesion. You can see on the right-hand side of the screen how I had to intubate deeply my guiding catheter into the RCA. But so far, I mean, the ostium of the RCA looks okay, and the patient is doing fine. So I went in, I placed that stent, and the next option was now to stent the whole proximal and mid segment. So we did not record what we did, but we took a long 3 by 33 millimeter Promise Premier stent to get it in, but it was almost impossible to get that long stent in. So I had to I decided then to use 2 shorter stents. So I took Promise Premier 3 by 24 millimeter stent and placed it in the mid segment with a plan to get another stent and cover the proximal segment with a third stent. And this is what I got. As soon as I inflated the stent here to stent the mid segment, I had this staining in the wall of the aorta. At that point of time, the patient started complaining of severe chest pain radiating to her back. She did a very severe bradycardia. She almost went to like 20 20 beats per minute, like almost a cardiac arrest. We had to give her 1 milligram of epinephrine and 1 milligram of atropine. And we restored a regular sinus rhythm. And we were aware that we have a dissection that extended from the RCA to the ostium of that vessel to the aorta. And this is the staining here in the aortic wall. So we were fortunate that this patient remained hemodynamically stable. And here, what you have to do, we have to stay calm. We should not lose our wire, and we should proceed very quickly and stent this ostium of the RCA where the dissection has occurred. So without taking further images of the RCA, because we should avoid injections into the vessel, because more injection in the vessels is going to lead to more dissection. So we did not do any injection. We immediately took this other 3 by 20 millimeter Rca stent, and we placed it into the proximal RCA with a proximal segment extending like 1 or 2 millimeter inside the aorta, and inflated it. And this is what we got. So this is after stenting of the ostium of the RCA. And this is the next view. As you see, there is no more staining in the aorta, so the dissection was completely sealed by stenting the ostium. And we finished by doing an aortogram. And as you can see here, there is no more stain into the aortic wall. We guess here the presence of a hematoma, but it looks okay, at least angiographically, and the patient was doing well. She was pain-free, she was hemodynamically stable, and she was happy. So in order to make sure that we didn't have tamponade, we did a stat echocardiogram, which revealed no tamponade and revealed a normal LV function. So it's a nightmare. It's a nightmare that we were able to deal with and to stabilize. But now the question, what to do? Is it safe to just monitor this patient for like a day or two and then send her home? Or should she proceed and have cardiac surgery to treat this parietal hematoma in the aorta? So we did a scan, and this is the result of the scan. As you can see, there is a big hematoma extending all the way up to the origin of the right brachiocephalic artery. And you know, we don't have really experience in those iatrogenic aortic dissection. Over 20 years of practice of interventional cardiology, this is the first time it happens with me. And you know, by reviewing the literature, the classification is either a dissection that is localized at the ostium, or one that is extending less than 4 centimeters in the aorta, or class 3 is a dissection extending more than 4 centimeters in the ascending aorta. So this is definitely a class 3, meaning that the hematoma extends more than 4 centimeters. So we had a long discussion with our cardiothoracic surgery team and with the patient, and we felt maybe the safest approach was to treat her surgically. So she went to surgery, you know, semi-urgently. She went in the afternoon for surgery and had her hematoma repaired and did very well and was discharged home. So in conclusion, this complication is really a nightmare. I don't think there is a consensus how to deal with the hematoma once you stent the ostium of the RCA. What we should do is we should stent this ostium of the RCA very quickly. And after that, should we send the patient to surgery? Should we wait and monitor? There is no consensus. But in this case, because the hematoma was longer than 4 centimeters in length, we sent her for surgery, and she did very well. So thank you for your attention, and I'm looking forward to discuss this case and answer your question.
Thank you very much, Dr. Rabih Azar with us live now, and I ask my panelists here, very short because we're running out of time. Start, Dr. Awad, your comment on the case, please.
Yeah, it's nice result. I think the writing was on the wall that calcified ostium is a prerequisite for dissection. So, and the catheter you used was really, if I may say, you were asking for it, but luckily enough, you managed to do it nicely. I congratulate you. We have another case like this, so we might delay the discussion till we get to see the other cases, if I may suggest.
Doctor, if you have any comment.
I agree completely with your comments, and this is what I said in the beginning.
the catheter played a major role in the dissection. But without that catheter, I think it would have been impossible to deliver a balloon or a stent to the mid-segment. And this is why initially I advised this woman to have surgery, but she didn't want.
Okay, we'll take the rest of the comments.
Yeah, great, Saif. Thank you very much for sharing this case with us. I think it's unpredictable again, but we have to take care, especially if there is ostial nodule or ostial calcification, to take care of manipulating the catheter. But I think most of those cases, this complication can be treated conservatively with good outcome.
Thank you, Dr. Rabih. Such a great case. I agree with you, it's rare to happen, but when it happens, sometimes they are devastating complications. The AL1 guide is a nightmare to deal with. I hate it. Even in the most calcified lesion, I try to avoid it. I would rather use guideliners, consider Rota in advance, rather than use AL. AL, it provides support on the expense of complications, and the complication could be dreadful, such in this case.
Jim.
Thank you for such a great save. Thank
Wael, if you have any comments.
Yeah, really a great case, Dr. Rabih, but why didn't you think from the start to go for atherectomy? It was, obviously, it was a very calcific vessel, and atherectomy would reduce the pressure you will use, because I'm sure that to deliver these stents, you had to push on the guiding too much. So that's what I think that's what we call rotor regret. I've been through this. Sometimes you say, I will not do rota, it will complicate the case. But in such cases, doing atherectomy from the start might save a lot of complication later. That's but at the end, it was managed greatly.
Okay, and Walid, Dr. Walid?
Well, thank you very much for sharing this complication with us. The first point that I want to mention, stenting the ostium is not enough, because this lesion will still leak and the dissection will extend up to the ascending aorta. If it should be stented with a covered stent, because even with the stent continue to leak around. This is number one. Number two, the dissection may go downward. It's not giving us pericardial effusion, but may affect the aortic valve. So we need further assessment of the aortic valve to make sure that she's not going into acute or chronic aortic regurgitation with that. And so that's, for me, I wouldn't have left this patient for a couple of hours. She needs further workup, and just the surgeon should be always present.
So,
anyway,
Dr.
Thank you very much.
Dr. Rabih, was this case done same session, or left and right?
No, we did the left coronary arteries immediately, like a couple of days after the diagnostic CAT. And then a week later, she came for the RCA. I didn't want to do both of them in the same setting. But all the comments that were done were well said, and I agree with all those comments, and we discussed them in length. And the surgeon came to the room immediately at the end of the procedure. And as I mentioned, we did an echo, and the aortic valve was fine. There was no aortic regurgitation at all. And then as soon as she left the cath lab, she underwent a CAT scan and went to surgery like a few hours later, the time to prepare her for surgery. So we didn't lose time. But I mean, if you review the literature, the consensus is not to put a covered stent. The consensus is to stent. Whether you use a covered stent or not, all you should do is you should first stent. And then if the hematoma does not extend more than 4 centimeters, a lot of case reports say that you can be conservative, you can avoid surgery. But as the doctor mentioned, if it continues to leak, because it can continue to leak, and the hematoma extends more than 4 centimeters, then it's better to operate. And this is what we did.
Okay, doctor, go ahead. You have a question here.
Thank you for your nice presentation. I'm a thoracic surgeon, not cardiologist. From the thoracic point of view, I agree with him absolutely. Anatomically wise, this kind of complication can happen. Of course, this is obviously very rare. But usually when it happens, it's very serious things, because if you open the aorta, you will see a tear around the right osteo, which goes hematoma to the aortic localized in these positions. Experience-wise, if you observe 1 or 2 or 3 or 4 hours, there is highly chance, more than 90%, it will extend to the root or to the ascending and to the main vessels. What it means, if you are referring the patient in early stage, this will be very small procedures with repairing of this tear without putting any device, any graft. But if it comes to complication and to extending of the dissection, then it will remain to the big surgery with root replacement, mental procedure, and hemi-arch replacement, what was done in this case. I don't know exactly what he did. And therefore, I advise, honestly, as cardiac surgeon, to refer the patient, because if it happens, and seriously, the mortality is more than 50 to 60%. At the beginning, this is almost zero mortality. That's it.
Or you could have avoided this by not doing the RCA. Hamid?
Quick thought. Thank you so much for sharing the case. Now, in retrospect, probably what I've done different is, of course, rotablation, okay, and extension catheter. And if I manage to get decent predilatation, okay, sometimes it might be helpful to stent actually proximal to distal. That would help you actually deliver stent distally, okay? And in the hope of minimizing manipulation with the catheter to avoid such complication. Thank you.
Okay, thank you. Rabih, you want to say something before we
No,
thank you.
I mean,
Thank you. Thank you.
All comments are great, and thank you.
Very kind for sharing your case with us. Thank you very much. So